Hello everyone. This is Dr. Yuan from the Department of Orthopedic Surgery. I guess you have known me for quite a while. And today I'm going to continue to talk about the trauma of the upper and the lower limbs. Last class we have introduced the overall general information of the fractures, and this is the content for the first half an hour about this upper limb trauma. Actually, the upper limb starts from the clavicle down the shoulder, elbow, wrist, and to the tips of the fingers. There are quite a bit bones and joints. Due to the time limitation, I just wanted to focus on the following 5 sections as listed here and talk them one by one. First, we are going to talk about the clavicle fractures, which is actually very common in clinical practice. The mechanism of clavicle fractures mainly due to a fall onto the shoulder, and in rare case, we have some patients got a direct blow result in clavicle fractures, and in some cases fractures resulted from a fall onto outstretched hands. According to the anatomic location of the fractures, we classify the clavicle fracture into 3 types. Type 1, the fractures are in the middle 1/3 of the clavicle, and this is the most common type of clavicle fractures, as shown in this image here. A second type is fracture located at the distal 1/3 of the clavicle here. This is the second most common type, and type 3 happened in the medial 1/3 of the clavicle here, and this is pretty rare. In my career, I only got 3 or 4 cases of the medial 1/3 fracture. For clinical evaluation, the patient will have serious pain on the clavicle area or even shoulder. If you check the patient, then you will find the local deformities or abnormal motions in the area of clavicle. And radiography usually the only examination we need to diagnose clavicle fracture. As I showed here, another thing I want to talk a little bit is the pattern of dislocation for this clavicle fracture. Here, if the fractures are in the middle 1/3 here, due to the traction from the attached muscle, the inner side of the fracture will dislocate a little bit upward, while this distal fracture end will remain in the same place due to the ligament contraction here. As this is a typical image of clavicle fracture in the middle 1/3. This proximal end dislocate upward. For the treatment of clavicle fractures, directly we will try conservative treatment, although this is not so commonly used in real life. We can use 8 bandage to immobilize the hurted shoulder for about 4 weeks. This is the maneuver used to reduce the dislocated clavicle fracture, and then immobilize both of the shoulders in this way. And this actually is a so-called 8 bandage, and the shape of this bandage is similar to the letter 8. Here are some commercial equipment used as 8 bandage. Here is another one, probably is much better than the bandage itself. Surgery is the most commonly used approach to treat clavicle fracture. The indication of the surgery is fractures with neurovascular injury or with severe associated chest injury, and the patient cannot endure multiple trauma or open fractures. Actually, open is not so common, and cosmetic reasons or uncontrolled deformity. For some reasons, particularly for young ladies, the clavicle area here is actually very important, particularly in the summer. And for some non-union cases, we use surgery to fix the dislocated or fractures. And here, in this case, we use key wire to immobilize, key wire as an internal instrumentation. And this is most commonly used stuff, which is plate and screws. And occasionally, if the fracture located at the outer 1/3 of the clavicle, we will use this clavicle hook. This is a half plate and half hook system. And actually, now this clavicle hook is not so commonly used, as this hook will produce potentially some complications or pains. Okay, let's shift to another topic, which is shoulder dislocation. Here is an image of kind of normal shoulder. The shoulder, this area, have a humeral head and a glenoid or scapula, and there are soft tissues surrounding the shoulder. The most common type of shoulder dislocation is anterior dislocation. A posterior dislocation is not so common, contributing about 10% of our patients with shoulder dislocations. The inferior are particularly rare, probably due to hyperabduction of injury. Here is the normal shoulder and anterior dislocation, posterior dislocation. And the anterior dislocation is the most common one, so we are going to focus on the anterior dislocation, which means the humeral head dislocated anterior relative to the glenoid. For clinical evaluation, you will find the patient's shoulder loses a round shape, as I showed here for this man. For the healthy shoulder, there's a round shape here, while this herniated, dislocated shoulder, you will feel this kind of square. Here is a right angle, and you will feel some empty here in this dislocated shoulder. Here is another case. Pay attention to the shoulders. You compare each other, you will find this here. You will find an empty shoulder, as this humeral head is located anteriorly. And there are substantial dysfunction of the shoulders. The patient typically hold the hurted arm using the health hand like this. I come to you for help. I cannot move the shoulder in any direction, perhaps. And another very useful sign for you guys to check the shoulder dislocation is Dugan's sign. For normal people, we let the patient have the elbow touch the chest and use the health hand to touch the contralateral shoulder. Everyone can make it. If the patient cannot make it, then it means the shoulder perhaps dislocated. Another way is just let the hand touch the healthy shoulder, and the elbow cannot touch the chest wall. This is also called Dugan's sign. Positive. It means the shoulder lost its function. X-ray is the most commonly used imaging to diagnose shoulder dislocation. Here is a normal shoulder, As I showed here, this is humeral head and this glenoid. Here is greater tuberosity, and this anatomic relationship are normal. But for dislocated shoulder, you will notice that the humeral head is located here, anteriorly and inferiorly. If you look carefully, you will find a little bit fracture of the glenoid of the scapula. Another case of shoulder anterior dislocation. Also, you will find the humeral head dislocated anteriorly, leaving an empty shoulder here. For the treatment, closed reduction should always be used. There are a couple of ways to reduce the dislocated shoulders. For example, the Asian way is called a Hippocratic technique, very effective for one person, and this maneuver was used even thousands of years ago. In some cases, we need proper sedation, particularly when the patient is really strong, very muscle, and even stronger than your arm. So if you want to check the patient, then you have to should do the reduction under anesthesia. That will help you a lot. Here are some very old maneuvers to reduce the dislocated shoulder. For example, in this case, using a very tall and strong man, try to hold the patient in this way and use this patient's gravity to check the dislocated shoulder. If the weight is not enough, they use another key to try to drag the patient down. Here's another funny way to reduce dislocated shoulder. Use a ladder. Let the shoulder cross over the ladder, and this guy will take out this bench and using this gravity of the patient to reduce the dislocated shoulder. Here's some complex stuff help to reduce the dislocation here. Here, I guess this is from 200 or 300 years ago. Using this tool help to reduce the dislocation. But nowadays, we do not have to use these complicated methods. As we have simply also called Hippocratic approach, you can reduce the dislocated shoulder by yourself using this way. Step on the pin of this patient and check the arm gently, progressively, and usually the patient's shoulder will be reduced. Here's now another slow way. Let the patient sleep down and this way, and let him bury some weight here, and gradually this weight will relax the muscle and check the shoulder down, and will reduce the dislocated shoulder. Here is another maneuver to this and that, and I didn't use this way for quite a while. And this maneuver actually is the most common one. You can try this maneuver in our department if we have some such kind of patients. For poster reduction here, we will find that the Dugas sign is negative. You let the patient do the touching the shoulder and chest wall. You will find that the patients can make it. Then its Dugas sign is negative, which means the humeral head is exactly in the location of glenoid. And the pain usually disappear immediately, but if the patient moves the shoulder, they will immediate mild pain. A poster X-ray film is very necessary to confirm the reduction, and usually we will immobilize the patient's shoulder for 1 or 2 weeks, and then start progressive exercise to rehabilitate the shoulder. Occasionally, shoulder dislocation need operative intervention. For example, if the shoulder cannot be reduced or failed to reduce due to the interruption or interposition of some soft tissues such as the shoulder capsule, in some cases the shoulder dislocation will have some fractures of the humeral head, and it's tough to reduce the shoulder. And in rare cases, there are habitual dislocations. The shoulder dislocates again and again, which means the capsule or soft tissue around the shoulder is relaxed. And in this way, we perhaps need surgery to repair the capsule and the soft tissue. Another topic is proximal humerus fracture, and this is most common fracture of the humerus. It's very common, the higher incidence in the elderly, probably due to the osteoporosis. And usually, older ladies are used to have these proximal humeral fractures. It's more common than a gentleman, perhaps also due to the osteoporosis, which is more common in older ladies. And these fracture perhaps most commonly resulted from a fall onto an outstretched arm from standing height. You do not need massive or high energy injury. Sometimes simply a fall to the floor will result in the proximal humerus fractures. If the fracture is only minimally displaced, then we simply use a sling to immobilize the arm and start early access rehabilitation, perhaps a couple of days after the immobilization. For complicated fracture, we need open reduction and internal fixation. For example, this is a shoulder proximal humerus fractures of an older lady, and we use locking plate and screws to fix the fracture. And this allows early exercise possible, which is good for a lot of old patients. Humeral shaft fractures are more commonly resulted from indirect injury, and the indirect injury will result in spinal or oblique fractures. There are some specific complications needed to mention here, as they are radial nerve injury, and they are pretty common delayed union or non-union happening in these humeral shaft fractures. For the clinical evaluation, you will find the patient come to you using the healthy arm to hold the injured arm like this to protect and reduce pain. You find substantial swelling and deformity in the humeral shaft. For the upper arm, a careful nerve examination is very important, as a radial nerve is in close proximity to the humerus and can be injured, which will result in wrist job. Particularly for the fractures of humeral shaft located down to the 1/3 of the humerus. Here, this area is very easy to injure the radial nerve, as the sharp fracture and will punch into the radial nerve, resulting in wrist job. So how to examine the patient? Simply let the patient do the wrist dorsiflexion. If it's fine, the patient can do this motion. If the radial nerve got injured, the patient will have a dropped wrist, and this needs your more attention. Typically needs surgery. For the treatment, sometimes you can try closed reduction and immobilization with a splint or hanging cast like this one, or these commercial stuff. And the goal of the treatment is to establish union with acceptable alignment. As you know, this up arm is not weight bearing, so the shape, the alignment is not so strictly required. The only thing is the union with acceptable alignment. And perhaps 90% of all humeral shaft fractures heal with non-surgical management. But in real life, particularly in our hospital, probably a lot of surgeons prefer the surgical treatment, as the surgical treatment got a lot of advantages. Open reduction, internal fixation by plate and screws, or internal locking nails are most commonly used method to fix the fractured humeral shaft. The indications include the inadequate reduction, non-union associated injury, for example, the open fractures, or vascular nerve injuries, or segmental fractures, which means the fractures are really unstable. It's impossible to immobilize using external splint or bandage or whatever. And for some massive vehicle accidents, the patient usually will have multiple trauma. So in this case, we prefer surgical intervention. Yes, here is a case. The humeral shaft fracture is comminuted, involving about approximately the middle 1/3 of the humeral shaft. And we use plate and screws to fix the fractures in this way. And as I've talked, the shape alignment of the humeral shaft is not strictly required, as we just need functional healing, not an anatomic healing. Another special type of fractures of the humeral is supracondylar fracture, which is more common in children, typically resulting in indirect injury. The kids are playing and fighting, and the pushing, as I showed here, will let the kid fall down, and the outstretched upper limb will injure around the elbow. Here is a serious deformity of the elbow joint. As I showed here, the fracture ends are really sharp, which is perhaps will hurt the adjacent vessels and nerves. Typical treatment and surgery. Here is the case. Anterior dislocated fracture of the suprahumerus, and is another case. Usually, fractures at this side are quite unstable, and we prefer surgeries which use K-wires fixation like this, as it's more common happening in the kids. The metaphysis is not healed, so we should use as less screws as possible. And in this case, it's good. We just use 2 nails, 2 K-wires. In adults, we can use plate and screws. Oh, I'm sorry, images don't show. Actually, this is my own cases, one of my own cases, but it's not here. Okay, let's talk about the fractures of the forearm. This also is resulted from the direct trauma of falling on the outstretched hand. Patients typically present in front of you with gross deformity of the forearm, with significant pain, swelling, and loss of function at the hand. Careful examination, physical examination is essential, with specific assessment of radial, ulnar, and median nerves and radial and ulnar processes. Tense compartments, unremitting pain, and pain with passive motion should raise suspicion for compartment syndrome. As you may know, this forearm is one of the most common places to have this compartment syndrome, which is a serious complication result from fractures. Here is a simple fracture of the radius. We fix it using plate and screw. Here's double fractures of the ulnar and radius. And in these cases, since that fractures are stable and we reduce